is indeed a very important one. It promises to be very exciting and educating. My name is Dr. Ibrahim Awoli from the Bafemi Awolowo University in Ife, and I'm the Assistant Secretary General of AFEMSIN. I'll be anchoring this session today. As I said, it promises to be very exciting. We have carefully chosen the topic of discussion for today. And before I move on with this, I want to quickly recognize the AFEMSIN president. You can see there Professor Falabi, ex-president, Professor Etu, been online for some time as well. Editor, VP, Professor Tupu, Professor Liani, and all other very senior persons that are on the platform. I welcome you all and I thank you for prioritizing this program. There are probably a million and one things we could be doing with our time now. So the issue of discussion. Preterm death is known to be the leading cause of death globally amongst newborn babies in the 28 days, in the, uh, in the first 1 year of life, up to the 5th year of life. Preterm death is the leading cause of death. And as the quality of care improved over the years, facilities to support babies that are born too early have also evolved such that we now continue to salvage babies that are born very early, depending on which part of the world we have. Despite the advancement in technology, however, we have noticed that while some of these babies survive, morbidities persist, which may be immediate or long-term lifelong morbidities that result in significant daily adjusted life year disabilities. Again, the cost of keeping these preterm babies alive is not small. And if we look at it presently, countries like Norway report perinatal mortality of about 2.3 per thousand, while Nigeria in the last NHS 2023 reported 67 per thousand perinatal mortality. So we as Nigerians, we must be very concerned about the issue of preterm death. It is in the light of this above discussed issue that the Association of Preterm Maternal Medicine Specialists of Nigeria, through its educational committee, has decided that we will bring ourselves up to date on the topic of discussion for today, which is titled Evidence-Based Update on the Management, which includes prevention, identification, and treatment of preterm labor. We intend to, at the end of this session, be familiar with what obtains irrespective of which part of the world we're practicing. We should be able to bring that knowledge and the evidence to our practice in Nigeria as well. So we'll be introducing our speaker for today. And to introduce this speaker, we have brought a very big personality who is renowned globally in the field of preterm death. I will invite Dr. Komomo to kindly introduce our eminent and erudite speaker for today, please. Dr. Komomo, are you ready?
Yes, good evening, sir. Good evening, everyone.
Perfect. Yeah, welcome. Please go ahead.
Thank you very much. Good evening, the president of AFEMSIN and every teacher and every person present in this meeting. We have a very wonderful speaker who is Professor Dili Anuba. Okay, let me use my video. Okay. He is a professor of obstetrics and gynecology in the University of Sheffield. He's a consultant obstetrician gynecologist in the specialty in fetal maternal medicine at Sheffield Teaching Hospital Foundation, the UK Foundation Trust in the United Kingdom. He is a clinical lead for maternal and fetal medicine and training program supervisor for the Fetal Maternal Medicine Foundation. He runs specialist clinics addressing pregnancy screening, prenatal diagnosis, fetal therapy, and prematurity prevention. Professor Dili Anuba serves on the Preterm Birth Committee at the International Federation of Obstetrics and Gynecology, FIGO. He is the Deputy Clinical Director at the Tommy's National Center for Maternity Improvement. He's also a member of the Council for the Royal College of Obstetricians and Gynecologists, the RCOG, and serves on the Preterm Birth Committee in FIGO. He's the principal investigator for many grants running into several millions of pounds, and these grants have been impactful in changing clinical practice across many countries and continents globally. He has also served on the NICE Medical Technologies Advisory Committee, MTAC. He also holds a master's degree in medical law and ethics. And he has numerous publications in international journals with over 5,000 citations. So this is just a brief citation of our erudite speaker and teacher, a professor of obstetrics and gynecology in fetal maternal medicine, a fellow of the West African College of Surgeons and Gynecologists. Please, our guest speaker, Professor Dili Anuba. You're welcome, sir.
Thank you very much indeed for the honor of the invitation. If I may, I'll just share my slides. Oops, that's open up the right one. And then we'll talk. So first of all, I want to wish every one of us a very happy New Year. Here in the United Kingdom, we stopped talking about Happy New Year by around the 10th. But in Nigeria, we're permitted to keep saying Happy New Year for as long as we like. And my hope and expectation and wish for everyone is that we have a really fulfilled New Year in 2025. I must start by, first of all, thanking our president, Professor Afolabi, and the organizers for the education, Professor Jamilu Tukur, for the invitation. And over the next 30 minutes, I'd like to cover evidence-based management of preterm birth, which in itself, as we all know from our wonderful AFEMSIN meeting last year, could potentially be discussed over a whole week. But I'll try to just give some snippets about the current thinking in terms of management from a mainly clinical perspective, laced with as much evidence as I can muster in terms of the time that's available to me. So in terms of what I'll cover, I'm really going to try and emphasize on issues around screening prevention, recognition and management of preterm birth. And as is customary for me these days, I'll talk about the health system's issues around organizing services so that we can have a holistic view to the challenge of preterm birth in Nigeria, in sub-Saharan Africa, and globally. So first of all, I'm going to go through some slides which many of us will be familiar with. In terms of what's the definition of preterm birth, and whilst doing so, I'd like to highlight some key global health issues. So preterm birth is, of course, birth before 37 completed weeks of gestation. But that's pretty much as far as it goes in terms of consensus and universality of adoption. In terms of the severities of preterm birth, there is clearly a disparity in terms of the survival figures for preterm birth. So a baby can be born alive or born dead, and a baby can be born too soon, as shown from this Born Too Soon report summary. In terms of a preterm baby, that would be a baby that is born before 37 completed weeks. And an extreme preterm birth relates to when the birth is before 28 weeks gestation, very preterm birth between 28 and 32 weeks gestation, and a moderate or late preterm birth before 37 weeks, but after 32 weeks gestation. Similarly, there are some disparities in terms of what's classed as a miscarriage, depending on which part of the world you practice in, and what's classed as a stillbirth. So in fact, although the WHO consensus definition of stillbirth is a birth after 28 weeks gestation of a fetus weighing more than a kilogram, this is rapidly becoming obsolete because births above 500 grams are deemed in most parts of the world as constituting a stillbirth if the baby is born dead. And there is even a move towards, as I'll show in another slide, considering births above 22 weeks as stillbirths rather than miscarriages. And clearly in lower resource, limited resource contexts, survival figures will vary. Again, I'll show some data from the UK and some other places. So for example, in higher resource contexts, more than 50% of babies, in fact, this is a very old slide because more than 60% of babies born at 24 weeks will survive, albeit some of them will have neurological sequelae. If we compare that to survival figures of, say, 32 weeks, again, this is obsolete because I think the gestation is less, where 50%, a baby born at 32 weeks, for example, has a 50% chance of survival in many low-middle income countries. So there are clear issues around definition, and therefore you can imagine that statistics is very varied in terms of comparability across different contexts. And in terms of the global burden of disease, we know that nearly 40 million newborns are preterm, which essentially comprises 1 in 10 live births. And of this number, about 1 million preterm babies die annually. And preterm birth is the cause of more than 40% of neonatal deaths globally. And it is also the leading cause of under 5 and perinatal deaths globally, as shown by much literature, including some that were just last year. So there's no doubt that this is a big global challenge. And coming closer to home in Nigeria, has a pride of place in the prevalence of preterm birth, as shown by the sheer numbers, where we number third in the world after India and China. And admittedly, that's because we're a very populous country. But it's nonetheless a big challenge for us that we contribute a high proportion of babies that have preterm, that are born preterm, as much as 5.3%. If you look at it in terms of percentages, we are also, as you can see from this heat map, Nigeria has a very high prevalence rate of preterm birth, as demonstrated by this Lancet Global Health paper. If you look at it in terms of neonatal mortality figures from 204 countries published in the JAMA, again, you can see the heat map up here that demonstrates that Nigeria is in the higher bracket of countries where not only neonatal preterm births mortality from preterm birth is high, but actually during the epoch of this particular study, you can see that there has been an increase. So the ones that are shown in red are the ones where between 1990 and 2019, there has been an increase in neonatal preterm birth deaths. You can see the mortality rates have increased. Similarly, if you look at it as a proportion of age-standardized mortality rates, again, the heat map shows that there has been a significant increase between 1990 and 2019. Now, it's arguable whether this is just with improving statistics, but the point of it is that there are many countries where it is not demonstrated to be increasing. Coming closer to home, it's hard to find really good literature because of issues around registration of deaths and births. But this is a paper published by our very own AFEMSN's Jamilu Tukur and Dr. Adesina as part of a group that did a database study looking at 62,383 live births that gave the incidence of preterm birth in this particular cohort at 15.5%, which is dramatically is higher than what is published in modeled estimates in the Lancet Global Health series. But the bottom line is that preterm birth rates in the in Nigeria is somewhere between 10% perhaps and 16 or 18%, depends on what the data sets are. But what's interesting and relevant to what I'll hopefully be discussing are the socio-demographic factors which their paper has shown are relevant, which are not dissimilar to global literature. So mothers that are aged less than 20 or more than 35 have an increased risk of preterm birth from this series. And interestingly, those that are not educated or where their partners are not employed, there is an increased risk. I've highlighted for us as a challenge the fact that women who have had no antenatal care whatsoever or have had less than the optimal number of antenatal care visits have a higher risk of preterm birth in terms of social demographics. What about in terms of the contributors to preterm perinatal mortality? I'm emphasizing this because this is more contextually relevant literature. Father's occupation is important, hypertensive disorders of pregnancy, preeclampsia, and again, the absence of antenatal care is a risk factor for preterm birth. And I highlight this because obviously there were ways and means you and I can improve access and utilization and coverage of antenatal care. It is possible that we can dent the preterm birth figures that you and I are aware of. So why is this such a big challenge, as Dr. Wowole has alluded to? The pediatricians can beat their chests because more premature babies are surviving as a result of some of these interventions that I'm showing here: better neonatal intensive care, better ventilation, better artificial feeding, more powerful antibiotics. And this has translated, particularly in higher context countries like the United Kingdom, in improving survival figures as shown in this graph. So you can see here that between 2008 and 2015, the survival figures for babies born between 22 and 23 weeks has in fact increased from about 30% in 2008 to more than 40% in 2015. And it's probably, I think it is, I don't have the data here in front of me, but it's probably attaining the sort of 50% mark very, very shortly, currently. Ditto for those born between 24 and 25 weeks, those born before 26 and 27 weeks. And by 32 weeks, the survival figures are so near 100% that you don't very much see any improvement in those figures. But the challenge for you and I as obstetricians and pediatricians as well, who may be in our audience, is that there has been very little reduction in the numbers of premature births born globally. And again, this is global figures that demonstrate the global prevalence of preterm birth in 2010, 9.8, 2020, 9.9, not a jot of improvement in a reduction of preterm birth rates. And if you look at a regional distribution of preterm birth, South Asia, Southern Asia has a very high prevalence rate, mainly Bangladesh and a number of India as well. And then we have Sub-Saharan Africa, and then and the rest are there. But every single one of these are showing no real change in figures. But I want to illustrate a trend that is probably contributing to this flat line of lack of improvement in preterm birth rates. And that's the contribution of the types of preterm birth that is evidenced in this United Kingdom Office of National Statistics figure. So whereas you have flat rates for overall rates, There is good evidence, certainly from most of Europe, that over the time period, the spontaneous preterm birth rates may actually, shown in green here, may actually be declining. But what's happening is that the iatrogenic or medically indicated preterm birth rates are on the rise, such that any improvements that are being made with spontaneous preterm birth is being counteracted by the increase in prevalence of iatrogenic preterm birth. And this is a real concern globally. I was at a meeting fairly recently where I was quite saddened to hear that in places like Egypt, the cesarean section rate has now exceeded 70%, 75%. And therefore, inadvertent delivery prior to 37 weeks is on the rise as well. So as we think about mitigating preterm birth, we need to think about ways of also addressing the challenge of iatrogenic or physician-induced or medically indicated preterm birth. And now I show this slide, but I'm not going to dwell on it because other slides will illustrate the issues. In terms of approaches to preventing preterm birth and reducing preterm birth deaths, there will be approaches that are aimed at predicting preterm birth for the purpose of preventing preterm birth. And there are interventions at a primary prevention level that have been evidenced to improve preterm birth rates. There are issues that can be addressed in terms of mitigation. And when the preterm birth is born early, there are interventions that can also improve the survival and reduce mortalities from preterm birth. And I'll dwell on some of these as we go along with the talk. So let's start, first of all, by looking at issues around risk factors for preterm birth. If we want to identify and prevent preterm birth, we need to understand what the risk factors are. And there are traditional definitions of risk of preterm birth that are demonstrated by the maternal demographics and past obstetric histories. So that's one way of assessing risk of preterm birth, is looking at the demographics and past obstetric histories. That's been ongoing for 30, 40 years. There's also secondary prevention, where what you then do is to try and identify those at the most risk, having undertaken population screening by selecting out the ones that are individualizing the risk assessment by assessing ultrasound cervical length and doing cervicovaginal swabs to look for proteins that are raised in those at risk. So those are traditional methods. And in terms of maternal demographic factors, which I won't have time to go dwell on in great detail, maternal age, domestic violence, smoking during pregnancy, low body mass index, teenage pregnancy. The Black race is a factor, which is quite fascinating in terms of why that is the case, multifactorial reasons. And if we go on to others, past obstetric histories, issues around previous preterm birth, previous late miscarriages, previous cerclage, no uterine shape variants, Asherman syndromes, and cervical surgery. So those are the main historical risks. In terms of other historical risks, we are increasing, and I'll show you evidence that previous delivery by cesarean section and full cervical dilatation is a big risk factor for subsequent preterm birth. Short interpregnancy intervals, less than 6 months, and again, we've talked about cervical treatments. So socio-demographics is important. But one of the key problems is that these relatively simple approaches to systematically quantifying risk at antenatal attendance is not available, and which essentially drove us to do the evidence manual for preterm birth risk assessment, essentially to sensitize practitioners to thinking about preterm birth when women actually access antenatal care in hospital. But not just to do that, but also to close the data gap that continues to exist as a result of poor recording or estimation of gestational age. Because if we don't know how far pregnant a mother is, we cannot categorically say how severely preterm the baby is. So these are interventions that are relatively at low cost and that can make a difference. But then again, these are tick boxes or checklist approaches to risk assessing for preterm birth. What is becoming clear is that checklist approaches are not quite as individual or as accurate as when for each individual patient, you look at all the risk factors and quantify it using risk prediction models or algorithms. And this is one of the algorithms that has been well validated through the Fetal Medicine Foundation, where you can categorize risk. Still very modest, but it is an algorithm that combines all these risk factors we've already talked about. What about cesarean section and full dilatation? This is an early study that demonstrated that women in a sort of a retrospective data set, that women whose vaginal deliveries were preceded by a past history of cesarean section and full dilatation, pregnancy continuation rates were much lower, shown in this red curve of this Kaplan-Meier, compared to pregnancy continuation rates for those women whose previous births were not attended by cesarean section and full dilatation. And the reason that's important is that because this lower segment takes up the cervix, it's very highly likely that the lower transverse section interrupts fibers that are proximal to the cervix, or in fact, the cervix itself, that renders the cervix somewhat insufficient in a subsequent pregnancy. And there are a number of reasons why that's the case. So this particular study is probably the latest study just published last year that had a huge cohort of 30,000 women who had cesarean section at full dilatation compared to other modalities of birth. And as you can see from the red boxes that I have highlighted here, that the odds of having a preterm birth between 24 and 36 weeks is twofold when you compare second stage cesarean deliveries versus all other births. And the odds continue to increase depending on the specific groups that you're looking at. And if you compare second stage cesarean deliveries in the cohort to elective cesarean delivery in this cohort, again, the odds ratios are significantly demonstrating a higher risk of preterm birth at all gestations. So if you're seeing women who have had a previous cesarean section, effort does now need to be made to ensure that we identify the risks as well as we can. And here is a case discussion. Sorry, I'm not here with you. I would have loved to be there with you all. That demonstrates the scenario. Someone who attended our clinic, my clinic, whose first child was full-term normal delivery, and the second child was also full-term, but had a cesarean section at full dilatation for failure to progress with a high head. Traditionally, you wouldn't think that she's at high risk of preterm birth, but when she came for a third baby, she delivered preterm at 26 weeks. Again, traditionally, you would think it was just an act of God, basically, which it is. But then she was referred because we're beginning to understand that there's a risk factor at 16 weeks. And the preterm birth prevention clinic that I run. So what would you do in that scenario, given this background? Would you offer her cerclage? Is that an overkill? Would you give her progesterone, or would you image the cervix? And if I took a straw poll, I guess you will all be right. And the answer is that we should image the cervix. And this is increasingly recognized as a method of stratifying women who have this risk. So we did a scan, and we can see this was only at 16 weeks that the cervix was already shut. There was a bit of debris, the so-called sludge. The cervix was measuring 15 millimeters. You can see the cesarean section scar there, the niche, the cesarean section niche, interrupting the anterior cervical lip. And we then did a cerclage for this lady. She still delivered preterm, but I suspect, I think she got to about 32 weeks before she delivered. So that's a real factor. So we move on to screening to individualize the risk secondary prevention, and that's by cervical ultrasound. I'll skip this because I'm sure we all know about this approach. The risk of preterm birth would increase as cervical length reduces. And all the studies have shown that all of the cervical scan parameters are predictive of preterm birth. If you could measure the os diameter, the funnel width, that's the funnel, or the cervical index, etc. And that when you do cervical scans, you do need to remember you need to scan for a minimum of 3 minutes. But this is a scan at the very beginning when I thought this cervix was normal. It measured 31.5 millimeters. And as we kept scanning and chatting to the woman to distract her, to us obviously to keep her relaxed, suddenly there was a wave of contraction that led to a big funnel and cervical shortening dynamically to less than just 9 to less than 10 millimeters. So do remember to scan over a period of time. It is important. But the problem is that many women, the number of women who actually have a short cervix, this is Kypros Nicolaides data from a long time ago that some of you will have seen in my previous talks, are very important. Looking at the length of the cervix and the risk of preterm delivery. So the longer the cervix, the less the chance of preterm delivery, shown on this on the y-axis. But as the cervix shortens, it becomes much higher. So the risk of delivery before 32 weeks decreased from 78% at cervical length of 5 millimeters. So even when the cervix is short, of 5 millimeters to 4% when the cervix is 15 millimeters. So 15 millimeter cervix, the risk of preterm delivery is low. And at 5 millimeters, it's even much higher. So the problem, though, is that the prevalence of the short cervix is very low. And because it's low, you would need to screen a lot of asymptomatic pregnancies followed by treatment to be able to prevent only a very few cases of preterm birth. And the other problem is that a good number of women with a normal length cervix will deliver preterm or will not be known to have a short cervix. And therefore, these are the major limitations of cervical length screening. The second method of secondary prevention is cervicovaginal swab protein estimation with fetal fibronectin, which, as you will know, in early pregnancy is low, but as the maternal fetal membranes and the interact, there is an increase in fetal fibronectin levels between 5 weeks gestation and 18 weeks gestation, as shown in this graph. Subsequent to that, it goes down and stays down less than 50 nanogram per liter. When there is perturbation in the choriodecidual space, the levels of fetal fibronectin go up during this gestational window after 21 weeks. And that's the basis of using qualitative or quantitative fetal fibronectin to estimate risk of preterm birth. And these are early studies that demonstrate that even in asymptomatic women, in other words, there are two categories of women you would want to screen for risk of preterm birth: women who are asymptomatic but who have a historical or demographic risk of preterm birth. Even in asymptomatic women, if you did fetal fibronectin tests, they are somewhat predictive of delivery before 34 weeks, delivery before 37 weeks, as shown by these areas under the ROC curves. But they are only modestly predictive, as demonstrated here with areas under the curve that are just above 0.5, 0.6. But what's very disappointing, and this has been demonstrated by a number of studies, some of which are quite recent, that among nulliparous women who have a singleton pregnancy with no previous historical risk, in other words, low-risk women, quantitative fetal fibronectin, even when combined with transvaginal ultrasound, have low predictive accuracies for spontaneous preterm birth. And therefore, they do not seem to be in support of their use in routine testing. But this is very controversial, and there's emerging evidence that routine screening will pick up some numbers of women with preterm birth. So if you are able to screen women, what are the interventions that serial surveillance of women at risk would enable you? So the first is to refer them to a local tertiary preterm prevention service, which is now quite almost routine in many high resource centers from between 12 and 16 weeks for a careful determination of risk, which is then followed up by serial cervical length scanning, progesterone, and other modalities. The interventions I've shown in various slides before, which work to varying degrees depending on the identified cause of birth. And I'll skim this, but this is all I'll skip this, but this is also shown in the algorithm in terms of static transcervical ultrasound scanning from sorry, there is an echo. I'm not quite sure where it's coming from. Is it something we could all mute ourselves, maybe? Okay, so you can undertake cervical scanning from 18 to 24 weeks, up till 24 weeks, looking for cervical shortening. That will then enable you to determine whether to give vaginal progesterone, and in situations where they have a previous history, perhaps consider cervical cerclage, especially in early gestations. I don't have time to go into that detail, but then moving on to twins and triplets, which I think we discussed briefly before at our FEMSN annual conference. The emerging evidence is that a short cervix in twins is good rationale for starting or offering them progesterone therapy. And there are challenges with progesterone, which we don't have time to discuss. But then, so I'll just focus on when do you initiate progesterone therapy. The thinking and the agreement, but the consensus is that you should initiate it from around sort of 16 weeks in most settings, but I would put here between 14 and 20 weeks and continue up till term. And it should be supported by serial cervical length scanning. And if the cervix shortens below 15 millimeters, if you look at key process data, then consider offering them cervical cerclage as well. Women with no previous histories who incidentally are found to have a short cervix before 24 weeks are also now almost universally and routinely offered natural progesterone until delivery. What are the progesterone preparations that I use? They're now natural or micronized progesterone given per vaginam. The dose is still contentious, but it's anywhere between 90 and 200 milligrams in many studies. And some people throw in an extra 200 milligrams if it makes them feel better. But the evidence base for going up to that dose isn't very good. The benefit of considering that is because of its excellent safety profile. And it's primarily used for women with a short cervix, especially if they have a history of spontaneous preterm birth. Where the evidence is not good still are those women whose cervixes are not short or who have no history of preterm birth, or where there is a singleton pregnancy succeeding a previous spontaneous twin delivery, especially if this was at term, but also even when it's preterm, because you don't know whether the preterm birth occurred because of multiple gestation or whether in fact there is a truly increased recurrence risk. When the fetal fibronectin test is positive only, there isn't any evidence to use progesterone. After cervical cerclage, there is very new data in the last 6 months that demonstrates some potential benefit to continuing progesterone, particularly in those who you have started progesterone prior to demonstrating cervimetric shortening, and then prior to offering them a cerclage, there is good evidence to suggest you should carry on with the progesterone. When the membranes are ruptured, there is no benefit to it. Maintenance therapy after threatened preterm labor, progesterone is not useful. And history of preterm birth due to preterm premature rupture of membranes is also very contentious. But because the recurrence risk is unclear, progesterone is not been demonstrated to be useful. So I'll move on very quickly to cervical cerclage. We have made there is a lot of advancement in terms of using cervical cerclage slightly more using an evidence-based format. Obstetric history-based cervical insufficiency is sufficient grounds for cervical cerclage. But there is not good evidence to suggest that cervical screening cervical length screening is required after you've actually placed the cerclage. And the opinion is split virtually 50-50 around whether you continue to offer women cervical length scanning. And I happen to be of the view that it's not useful because there is no other intervention, especially if they're already on progesterone. There isn't any benefit in continuing to measure women, even if you look at the length of the cervix before or after the proximal or distal to the actual stitch itself. Ultrasound-based cervical insufficiency, less than 25 millimeters, especially if you demonstrate cervical dilatation. Treat with vaginal progesterone. Physical examination-based cervical insufficiency if you don't have access to ultrasound, but then that's again not very evidence-based approach. Perioperatively, the jury is out as to how best to prepare, but some of us will give indomethacin parectum because it's probably the most powerful tocolytic agent to quieten the uterus, and give prophylactic antibiotics as well preoperatively, and continue the cerclage thereafter. What about transabdominal cerclage? There is good evidence that it can have its place, especially if there's been a failed live birth after one elective transvaginal cerclage. If there's been ultrasound shortening and a rescue stitch or an emergency cervical cerclage that is not elective and there was failure of that, you could potentially offer such women an elective transvaginal in the next pregnancy rather than cervical. It's also useful when the cervix is extremely short or absent in scenarios where cervical treatment, surgical treatment has been performed, or there is obvious cervical scarring that is clinically detectable. There are some studies, and perhaps the most persuasive is the Maverick trial that has been published by the Shannon's group in the American Journal. And there are good reports of laparoscopic transabdominal cerclages that are very, very promising and suggest that it probably is as good as this open technique. So what about future pregnancies following cerclage in the index pregnancy? And this is a challenge that I'm sure all of us, many of us will have come across, especially when the indication for the previous cerclage is unclear. So prior successful outcome after cerclage, and there has been an established history of pregnancy loss, should trigger a vaginal cerclage at 12 to 14 weeks. Although most studies, and for brevity, I'm not citing every single one of them, suggest that outcomes are similar to if you serially monitor cervical length and only offer the repeat cerclage to the subsets that demonstrate cervical shortening. There are many women who have a cerclage for no reason who we just monitor by serial cervical monitoring, and they don't require a repeat cerclage. Prior unsuccessful successful outcome for vaginal cerclage is offer transabdominal. Prior unsuccessful ultrasound indicated cerclage, offer vaginal cerclage electively early. If unsuccessful, then offer transabdominal cerclage. So having talked about cerclage, let me very briefly talk about evidence for potential use of therapies to reduce indicated or iatrogenic preterm birth. And perhaps the most promising is, and the most useful in current practice, is the use of aspirin to reduce high risk, to reduce the incidence of early onset preterm preeclampsia and preeclampsias. And there is now no doubt that early onset preeclampsia is mitigated by aspirin. And the reason this is relevant to considerations of the risk of preterm birth is because 10% of preterm births will occur because of hypertension in pregnancy. So if you reduce severe preeclampsia, you can mitigate preterm birth incidence. And indeed, you will probably be aware of this study in low-risk settings across a range of countries that demonstrate that nulliparous women who are given in a singleton pregnancy, who are given aspirin from early pregnancy, had a lesser risk of preterm delivery early preterm delivery, and lesser chance of perinatal mortality with just aspirin treatment, even in nulliparous women. So that's a very interesting concept, which is gaining a lot of traction in terms of how this can be taken forward. Fetal fibronection. Now we move on very quickly to symptomatic preterm birth. In other words, the women with or without a previous history come huffing and puffing and saying that they're in labor or are having uterine contractions. Fibronectin is probably was the gold standard for predicting the risk of delivery within 7 to 10 days of the index assessment. And you can see from this area under the curves that the cervicovaginal fibronectin in women presenting with symptoms of preterm birth had a reasonably high accuracy for predicting the subset that will deliver within 7 to 10 days. And it's not quite as good for predicting those who deliver preterm, even in these women who are presenting with symptoms. And fibronectin has been the mainstay of treatment, but you and I know that it is not cheap. It has major limitations, and we moved from qualitative fibronectin, where it's a positive or negative agent strip that tells you whether the quantities are more than 50 nanograms or less, to a more quantitative approach where you actually measure the concentration of fetal fibronectin in cervicovaginal secretions. And using the quantitative methods, you can pick up nearly 80% of those that will deliver within 7 to 10 days with a reasonably high specificity. But the problems with fibronectin, which has limited its use, recently culminating in the withdrawal of Hologic from producing fibronectin globally, which again poses a big challenge, are the false positives because of a range of different physiological situations. And as I've alluded to, the quantitative approach has been shown to demonstrate improved prediction values. I'm sure we're all aware, and some of us will have access to practice where you also look at other proteins. Patosure is one, and the other is actin patos, which are different proteins that are placentally derived. Alpha microglobulin 1, PAMG1, is probably arguably the most sensitive and the most accurate for predicting delivery within a matter of a week of the timing of the assessment itself. And a variant of Patosure is Amnisure, which essentially is used to detect ruptured fetal membranes. But sadly, these are all not cheap at all. And therefore, in the context of our practice back home in Nigeria, it will be limited by issues around availability, issues around access. So which is better? In terms of actin patos and fetal fibronectin, this is an old study that demonstrated that actin patos has higher false negative rates, lower negative prediction values, but has lower false positive rates and therefore higher positive prediction values. I'll skip this for lack of time. If we looked at Patosure, which is arguably the best that we have today, a comparison with fetal fibronectin, you can see this study that was published in the Journal of Perinatal Medicine a good while ago, demonstrates better sensitivities for Patosure, better specificities, positive predictive values, and negative predictive values for Patosure. And this is also shown by an independent study that was published slightly more recently in the White Journal, that again demonstrates that for high-risk groups, PAMG1, that's Patosure, has better positive predictive values, which was always the pitfall of all of these approaches compared to fetal fibronectin and actin patos. But the big limitation is cost. And even in high-resource countries, that's not yet something that is in good use. And this algorithm purely summarizes what most contexts use for differential diagnosis of a threatened preterm labor. I want to highlight the real hallmark or the highlight of affordable approaches which look at cervical length and cervical dilatation, both digitally but also by ultrasound. If you can do that, you can pretty much, for now, get rid of the need for cervicovaginal swab tests. And this is something that is becoming increasingly recognized as a means of identifying those women who would potentially be kept in hospital or sent home. So just to put all of this in context, one of the problems with preterm birth is that it's a syndrome caused by a range of very different things. And therefore, it's unlikely that we'll ever find the pill or the capsule or the intervention that treats all preterm births. And it is recognized that algorithms are going to be needed. It is recognized that small interventions here and there will add, with small effect sizes, will need to contribute to reducing the risk of preterm birth. And this is a study in Australia that showed that 6 interventions highlighted here, a few publications: ultrasound cervical length, use of progesterone for short cervix, or with cervical cerclage, avoiding iatrogenic preterm birth by just using cesarean sections for proper indications, aspirin, smoking cessation, use of dedicated preterm birth prevention services, reduced the preterm birth rates in tertiary centers in this part of Australia over a time period between 2013 and 2017, as shown here, particularly for the overall category. So you can see the preterm birth rates there. Sorry, this is a rather busy slide. The rates reduced over time when the 6 interventions were used together. The take-home message being that if you did everything you can do with the evidence that you have, we might begin to dent the risks of preterm birth. And the summary of their study was that after 18 months of this 6-point care bundle approach, there was a reduction in preterm births of less than by about 200, including more than 40 preterm births that would have occurred at less than 32 weeks gestation. So what about fertility treatment? And in our context, this is important because in many contexts, the number of embryos that can be put back is now limited to 1 or maximum 2. And the rationale for that is that if we want to reduce preterm birth rates, elective single embryo transfers are associated, based on some of these systematic trials, with lesser preterm birth rates compared to double embryo transfer conceived infants. So the take-home message is that at some point we're going to have to think locally about how to restrict embryo transfers and fertility treatment, accepting that there are contextual challenges in situations where affordability of IVF is in itself already a problem, and most women would want you to put back 4 embryos so that if they're lucky, they'll go home with 1 or 2 babies. So I recognize that that's a context. So having talked about that, what are the interventions? If you are going to generate a care bundle, what are the interventions that you would want to use to do that? And we did a bit of a systematic review, a mapping review of systematic reviews that demonstrated the lack. These are low-income countries, low-middle-income countries, high-income countries. And these are showing where primary studies were done. And you can see that even for preterm birth, that is a low-middle, that is a global problem, most of the studies shown in orange were actually done in high-income countries where it isn't as much a challenge as it is in under less developed economies. But in terms of interventions that are known to work, depends on whose systematic review you read. There is a lot of variation in what is evidence to work, but this was the short list of those whose confidence intervals did not cross unity that demonstrated potential utility. For lack of time, we won't go into the evidence for each of them. But these are interventions that were known. But in terms of what are the key ones that are best evidence, so the FIGO Preterm Birth Committee, we put together what we have called, and I'm sure we discussed this within our WhatsApp group, the FIGO Prep 5, which are key initiatives, 5 of which are the best evidence that are non-controversial and simple, affordable, that if instituted in most care settings will reduce or mitigate preterm birth. Antenatal corticosteroids, magnesium sulfate for neuroprotection, delayed cord clamping, exclusive and early breast milk feeding, and kangaroo mother care. And that's a lot of evidence around it, so you can read the paper. So this has informed a lot of practice in terms of optimizing. So we've moved from prevention, we've moved from screening to prevention, we're moving to mitigation. If, despite our best efforts, the baby is born early, how can we optimize the outcome by reducing the consequences? And that's the basis of a lot of initiatives everywhere, and I guess the same in Nigeria. But in the United Kingdom, most hospitals now have what's called a Preterm baby passport, where a woman who presents in threatened preterm labor has a sticker that has all of these interventions, the Prem Prep 5 and all the others, although this was way before Prem Prep 5, which was only published recently, where the care workers make sure that all of these interventions are ticked as having been accomplished for the woman. The first question, and I'll show you some evidence, is around the right place of birth and the need to move the person to where the baby will get good care. So in utero transfers, and I'll show you evidence, and you probably already know that in utero transfers are the best ways of transporting preterm babies. Has the woman received antenatal steroids, magnesium sulfate? Have they had antibiotics, etc., etc.? If they are in labor, can we ensure that they have delayed cord clamping to improve placental transmission of blood to the baby and improve survival? So what's the evidence? So babies delivered at less than 27 weeks gestation or with an estimated birth weight of under 800 grams should be born in maternity services on the same site as a designated NICU. And there is good evidence, which is partly what I show here. There's plenty of literature to suggest that if you have a woman who's about to deliver preterm, please move them to a unit where there is a neonatal intensive care. Don't deliver them in a facility and then transport the baby moribund to a unit with neonatal intensive care facilities. And this is a study that was published quite recently that demonstrates that the outcome is much better if mothers are transported in utero to a NICU facility. The severe brain injury rates are less, 25%, than controls in terms of the risk of a brain injury. And this is shown, I think this is the table that I was going to use to demonstrate that more. So you have severe brain injury there, which is if pairwise matching of extremely preterm non-transferred babies in non-tertiary units with local neonatal care units. So you can see that the non-tertiary units had a much higher severe brain injury percentage, 13, compared to those ones where they were transferred. Similarly, survival without severe brain injuries were higher in those that were moved up to facilities where there were neonatal intensive care facilities. So the take-home message is to move patients with the mother still pregnant to facilities where they can then be delivered. Antenatal corticosteroids, I will skip this very quickly. There is no doubt of benefit in terms of reduction of respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, or in fact neonatal mortality, as shown by many reports, including the Cochrane reviews of this and the ACT trials themselves. Later gestations, even if you gave it between 37 and 39 weeks, there is some evidence that it reduces transient tachypnea of the newborn and neonatal respiratory morbidity, although there's a lot of contention now as to whether that is well worth the risk of making babies smaller, which repeated steroids will cause. So what's the nice guidance from the United Kingdom, which may be somewhat relevant to your practice, is that if there is suspected, diagnosed, or established preterm labor at between 22 and 24 weeks, discuss steroid therapy with the family, and we'll have a multidisciplinary team meeting with the neonatologist to determine whether you give it to women at this gestation. However, if it's after 24 weeks, offer the women steroids. And if it is after 34 weeks, particularly, consider steroids in that particular setting. And I suspect that in our own context in Nigeria, it may be that steroids will be given. If we had an interactive meeting, I'm sure you'll educate me, from 24 weeks or from 28 weeks. Do you need to repeat steroids? Yes, you could for women under 34 weeks gestation if they're delivering imminently, but no more than one repeat is advisable because the babies become smaller. Repeated steroids cause fetal growth restriction. I recall not terribly long ago looking after a woman who had severe Crohn's disease and was on prednisolone right through pregnancy. And was referred to me with severe fetal growth restriction. And once discussions with the medical team led to a reduction in steroid intake, the baby's growth accelerated almost instantaneously. So there is a real risk to inordinate use or too much use of steroids. Magnesium sulfate for neuroprotection. There's a Cochrane review that demonstrated that women in threatened preterm birth before 30 weeks should receive magnesium sulfate because it reduces risks of cerebral palsy and probably reduces severe intraventricular hemorrhage. And that's, again, is a forest plot that demonstrates the summary here that there is a reduction by as high as perhaps 0.7%, 0.7 or 70% reduction in risk of cerebral palsy by 2 years of age in the studies that I've shown that. The next important routine is that women who are in threatened preterm labor should receive benzyl penicillin or clindamycin if they are penicillin resistant, if they're allergic, to penicillin. And it should be given for, if possible, more than 4 hours before the delivery to reduce the risk of GBS. That's group B hemolytic streptococcal infections. And this is the RCOG Green Top guideline that gives an algorithm of management to prevent group B hemolytic streptococcus. And I'll not run through the entire slide, but you can see in the context of preterm labor management, the guidance remains that we should offer intrapartum antibiotic prophylaxis, IAP here, for women in preterm labor, and also for those who have had a previous history. This in itself is a discussion we can have for many hours. Delayed cord clamping, the evidence is clear from randomized trials as well. And our neonatal colleagues also undertake a number of other interventions when the baby has already been born, carb feed, probiotics, and prophylactic hydrocortisone. As I round up, I move on to tocolysis to delayed delivery. And this is a rapidly failing science in the sense that from giving lots and lots of women drugs to stop uterine contractions, its use is now limited to delaying delivery purely for the purposes of facilitating steroid administration and in utero transfer. And therefore, once these two aims are achieved, the consensus based on evidence is that one should stop tocolysis. Stop 12 hours after the steroids have been given or immediately after in utero transfer. The drugs that are favored include atosiban, nifedipine, and indomethacin. Atosiban, on grounds of cost, is now falling out of favor. And the National Institute for Clinical Excellence here in the United Kingdom, we all now use nifedipine as first line, but can move to atosiban if it is contraindicated. Or if contractions persist and you're really desperate, then atosiban could be used instead. Indications are clear, threatened preterm delivery between 23 and 33 weeks, evidenced by uterine contractions, and the diagnosis of preterm labor without cervimetric change. If the cervical dilatation is more than 3 centimeters, it's not worth starting because the evidence suggests it doesn't work. Many contraindications that you and I will be familiar with, and I have listed them here. Bleeding, suspected abruption, severe eclampsia, or severe maternal conditions where expedited delivery is mandated. There are contraindications to nifedipine. In terms of regime, you can start with 20 milligrams. Modified release tablets are best because they work slowly over time and reduce the risk of hypotension and headaches. And you can escalate the dose to 20 milligrams 3 times a day, but try not to go beyond that because it causes headaches. Monitoring blood pressure, pulse rates, and temperature. And reviewing the dose if the systolic blood pressure goes below 100. Avoid indomethacin after 32 weeks. We all know, we are all taught this in pharmacology because it causes premature closure of the ductus. And there are controversies as to whether you switch from if the first line is ineffective. Many people would not switch, many people would simply deliver at that stage. And there is no evidence to suggest you should use 2 tocolytics concurrently. So I end by just talking a little bit about the health systems issues and the fact that preterm birth is best delivered in existing care models that involve not just us as obstetrician gynecologists, but also other doctors in the private sector. 30% of births in Nigeria occur in the private sector. That involves community health workers, midwifery, midwives, and sometimes might in fact be helped by group antenatal care where the one-to-one care is not necessarily possible. But the model of care is important, but the biggest challenge is to ensure that people are aware of the challenges of providing this care from the point of view at the primary level, secondary level, tertiary level, and that prevention and risk assessment is important initially. And that even when preterm birth is occurring, once you've determined the gestational age, which starting with gestational age, it's best that it occurs in a setting with where the neonatal intensive care is best. So where the woman delivers should really be informed by the presence of neonatal intensive care facilities and not necessarily by who has been providing the private care elsewhere. A multidisciplinary care pathway is important. So in your own setting, I want to challenge you to set up a team of people who are going to be motivated to provide the best care that these women need, starting from pregnancy care right up to delivery and into the postnatal period. And my final slide is really a challenge around data collection. And it's heartwarming to see Dr. Adeshino's and Professor Tuku's paper that demonstrate the big push to improve our data collections, because that's the only way we're going to understand how and make the data of good quality, improve the accuracy of the data, and that's the only way we're going to begin to understand whether we're actually making inroads in terms of mitigating preterm birth in Nigeria and sub-Saharan Africa. Thank you very much.
I could see some reactions, some people clapping, and many people expressing their gratitude to our speaker, Professor Dili Anumba. Thank you very much. I don't have the capacity to thank you, so I'm not going to put into that territory. The plan was to look at the evidence. I mean, the title was carefully selected, evidence-based update. And I'm sure everybody will agree with me that Professor Anumba was in his element during that discussion. Thank you once again. We I appreciate your presentation. I am sure that we will have questions and clarifications um, to seek from our guest speaker. But before that, may I seek the indulgence of the audience to quickly take about 3 minutes to remind us all that this educational webinar is one of the core mandates of the Association of Fetal Maternal Specialists of Nigeria, AFEMSIN, and AFEMSIN um, is a subspecialty that aims to manage high-risk pregnancies, thereby reducing the adverse and bothersome maternal and perinatal mortality and morbidity indices in Nigeria. We aim to build capacity, to advocate, to conduct research, and to promote training. We are calling for people to join the organization, and there are immense benefits from such. This webinar is one of those core mandates, as I said earlier, and we are open to consultants who have their fellowships in the National College or the West African College or equivalent, with a registration fee of 20,000 naira and 10,000 naira annual due. We are also open to associate members, resident doctors, house officers who wish to start early. They can all join us. They enjoy rebate with respect to the annual fee that they have to pay. We are a collaborative organization, so we also welcome our colleagues from radiology, pediatrics, and neonatology specialty, geneticists, counselors, sonologists, nurses, and midwives. So if you want further information about AFEMSIN, please visit our website, www.afemsin.org. And it's a very interactive website, very friendly. You will read about us there. You can choose to join and make payments to join the association through our website. If you have further questions, you can also reach out to any of us. We will be more than willing and glad to help you out. And may I also say that though he's in the diaspora, Professor Dili Anumba has never hidden his passion and support for our person. He's always committed his time and resources to be with us in our program. He attends our annual symposium and he makes very relevant contributions. So thank you once again, Professor Anumba. That is a very fantastic and educating talk for which we are very grateful. If there are questions, please signify. I will also be checking the chat room now to see whether anybody has sent in a question. Or please, by a show of hands, if anybody has any question about um, the lecture by Professor Numba, can we take them now? I'm looking through the chat now.
I can see two questions, Dr. Wale. One of them is about how to determine the antibiotics to use since we don't routinely screen for GBS here. And the second one is about dose of magnesium sulfate for neuroprotection.
So the antibiotic of choice, you don't need to do any screening. It's routinely now, it's benzyl penicillin because it covers for GBS. If for any reason you happen to have facilities for checking whether they are penicillin allergic, then you can use clindamycin or any of the other broad spectrum antibiotics that affect gram-positive cocci. So that's, you don't need to know. All preterm births now in my hospital and in the UK get given intrapartum benzyl penicillin if they're in labor. So that's the first question. The second question was, let me.
Dose of magnesium sulfate.
Yeah, so the dose for magnesium sulfate is the same as what we use for prophylaxis against eclampsia. So the same dose of loading dose of 4 grams, followed by a continuing dose. And the idea is to give it for the preceding 4 hours before the birth of the baby. So, and then you carry, yeah, so that's the dose. Same as for preeclampsia and eclampsia. So that should make life for eclampsia prophylaxis. But that's easily available in many of the guidance, global guidance that you can lay your hands on. So again, it's
Thank you very much.
remember issues around magnesium sulfate toxicity. So the same guidance is needed to be careful with dosing, because toxicity is a real risk. So still look out for reflexes. If you have access to monitoring levels, fine, but otherwise check respiration regularly and do the reflexes as you should. Yeah.
Much, Mr. Anunda, for answering the questions. Do we have, okay, somebody just sent in another question, Dr. Indo Audu. Is there a rule for bed rest in the prevention of preterm death in patients at risk?
Yes, that's a very interesting question. And the answer is that there is no one knows for sure the extent to which bed rest is useful and for who bed rest is useful. But I think it makes sense to say that women who have a very high risk of preterm birth should have some bed rest. But if they have to have bed rest, then do make sure that you give them thromboprophylaxis whilst they're in bed. But it's not bed rest to the extent that they have to necessarily be confined to bed. It's about reducing exertion, physical exertion. In terms of women who I've had some anecdotes where women have done incredibly well because of bed rest, including women who've had spontaneous rupture of membranes. One of my star patients in the last 6-7 years was so determined not to lose her pregnancy. She admitted herself to my ward and stayed in bed until and just refused to allow the liquid to gravitate out. And actually, she did deliver and have a successful outcome. But that's pure anecdote, completely unusual. Her determination was just impossible. But bed rest, the evidence for bed rest is not well established. But we still use that, particularly for those who've had previous bad histories. Women who've had trachelectomies, where the cervix has been amputated and they have a transabdominal stitch, you may want to bring them in and keep them in from here. It will be from 22 weeks. In your setting, it might be slightly later until such a time as the pregnancy is viable. So we don't know the answer to that, but I think it makes sense. It makes them feel better that they're in hospital. It makes you feel that you've done everything you can, and they don't blame themselves, which is also part of the problem.
It's an important part of managing the patient. Thank you very much for that, Prof. I have one other question here. It says that in terms of topology, what is the cause of cervical dilatation? How would you not recommend policies?
Sorry, I didn't hear you too clearly. What is the cutoff cervical dilatation when?
After which you would not recommend using Foley.
Oh, using the Foley. Well,
Tocolysis.
sorry. I thought you were talking about rescue stitch. That's a different matter. Tocolysis would be 3 centimeters, because if a woman is more than 3 centimeters dilated, she's pretty much in labor. Well, she will be in labor, and it's unlikely to work. Now, you and I know that there are women who have remained pregnant at cervical dilatations of 3 and 4 even, and preterm, who are in threatened preterm labor, but they will probably have remained undelivered with or without tocolysis. The evidence isn't good enough for one to continue to recommend that. Once you've achieved, given the steroids, usually at least 1 dose, but preferably the 2, there's no need to continue tocolysis for anybody, regardless of cervical dilatation. And if they've gone beyond 4 centimeters, it's even less likely to work.
Okay, thank you very much. I have an interesting question here. Somebody has talked about the interventions that have been shown to improve the outcome of preterm labor and preterm death. And the person is curious as to why we haven't emphasized the role of MNICU, Modern Neonatal Intensive Care Unit, as a concept to improve outcome.
Yeah, very good point. I totally agree with this person. It's so very important. It's more around optimizing outcomes. But this was aimed at obstetricians, so I was focusing on our own interventions. Once we, the issues around how modern our intensive care units are is a matter for the pediatricians. The key thing is for us to ensure that we deliver our women in the best places where we have neonatal intensive care. So where the person should be delivered should not be determined by where the best obstetric surgeons are to do the C-section. It should be determined by the neonatal intensive care unit where there are the best facilities, even if it means transporting them elsewhere, accepting there are logistic issues around costs, availability, and funding. So I agree with the person who asked the question that it's an important aspect. And that's why the survival figures have been improving. If you remember, I mentioned the fact of changes. That's because of interventions and better neonatal care. Very important also back home, here in Nigeria.
And thank you very much. Your lecture has triggered a lot of questions today, Professor Anumba. So somebody is asked, can we start progesterone before 14 weeks of gestation?
So I guess there are many women who have progesterone before 14 weeks because of recurrent miscarriage or thrombophilias or other things. So for those ones who are already on progesterone, we would normally just carry on. But if it's for purposes of providing prevention of early delivery, then all of the evidence is from early as 16 weeks or so. And that makes sense because before, this is small print stuff, but before intramuscular progesterone was withdrawn, as you will recall, it has both progesteronic effects, it also has anti-progesteronic effects. So the earlier New England Journal papers show that use of progesterone, that particular synthetic method, was associated with a slight increase in miscarriage because of the anti-progesterone effects. So the point I'm making there is that starting it too early does not mean that it works better. In fact, the principle of avoiding drugs in the first trimester of pregnancy still applies. And therefore, I wouldn't recommend progesterone for preterm birth prevention before 14, 16 weeks. But if it's for recurrent miscarriage, that's a different matter.
Okay, thank you very much, Professor Anumba. Our president, Professor Afolabi, has to leave. May I ask if Professor Afolabi has any comments before he leaves, please? Professor Afolabi, please. Okay, while we're waiting for her, if she has any
I think she's
comments.
probably left.
She's still on the platform, but I guess she's
okay.
busy. The last question here is about abdominal sac life, which is preferable to do it pre-pregnancy or to do it during pregnancy.
There isn't good evidence to suggest that one or the other is preferable, but most people would go for the pre-pregnancy cerclage, provided there are no, so pre-pregnancy cerclage would make a lot of sense in that regard, but also in early pregnancy is an option. I don't know of any evidence that suggests that one is better than the other. It's more around patient preference, but also surgical preference.
Oh, fantastic. We have had a very fulfilling and illuminating session today, Professor Anumba. Thank you very much. But that is from me. I will be inviting the editor-in-chief of the Offensive Journal, Professor Ladapo Olayemi, who I think has sufficient clout, timber, and caliber to thank you on behalf of Offensive to give the vote of thanks. Professor Olayemi, please. Thank you to all our participants that have joined. We had over 200 participants in attendance today, which is really great. I'm sure your lecture will have significant impact. Is Professor Olayemi available to give the vote of thanks?
Why is it that the meat they are buying now, they look the same?
It does look like Professor Olayemi is not immediately available.
I'm here.
And, oh, fantastic. Prof. Davis, you are welcome. Please kindly do us the honor of giving the vote of thanks and especially appreciating Professor Anumba for this very educating session, sir.
Well, I'm sure that everybody here agrees that that was a very, very technical yet simple delivery. I mean, I learned a lot in terms of delivery skills of lectures from him. And I must say, we as AFEMSIN, thank you very much for agreeing in spite of a very busy schedule and other engagements to give this talk, and that we also appreciate your continuous support of the organization. And we hope that in future, when we call you, I will definitely call you for the AFEMSIN conference in Ibadan. Let me just put that down now, leave that marker. And we hope that you'll be there for us as usual. Thank you very much. And thank you everybody for coming, especially those who, I must be very grateful for those who attended, because this could have been organized and we didn't have people to attend. I recorded at least 209 at one point in time, which is a huge attendance. Thank you very much, everybody. Thank you, AFEMSIN, for organizing things, the Educational Committee. And thank you, Dr. Owoli, for being a wonderful compare. So God bless everybody. Thank you all.
Very much, Professor Olayemi. The president just sent in a text that our peak attendance was 240 participants during the lecture, which is great. On a final note, I will give this announcement that we have a very fascinating session coming up on our next webinar, and it will be delivered by no other person than our erudite Professor Bosede Afolabi, who is the president of AFEMSIN. She is well known for her research capabilities, and she will be talking about practical tips on the use of iron therapy for treatment of anemia in pregnancy. I have no doubt that we all agree with me that anemia in pregnancy is of major concern to any obstetrician practicing in Nigeria, and I believe that it's promising to be very educating as we will anticipate and expect. Thank you, everybody. Bye-bye. Have a pleasant evening.
Thank you.